Okay, so Unit 6, we start with determining priorities to planning patient care. This is where we start looking at our core measures, and if you've worked in acute care, you're probably familiar with that term. The Centers for Medicaid and Medicare Services do establish these measures. Um, some of the important ones are focused on here, although there are more in the course of study. So one of them is blood pressure, and they base that on some criteria. Goals would be for ages 18 to 59 that we maintain blood pressure less than 140 over 90. For those patients who are 60 to 85 with diabetes, we want blood pressure less than 140 over 90. And for patients 60 to 85 without diabetes, we want blood pressure less than 150 over 90. The next core measure we want to talk about that's pretty important is beta blocker treatment after heart attack. So patients who are 18 and older who have an acute MI must receive a beta blocker for 6 months afterwards. And then those with ischemic heart disease, patients 18 and older with acute MI, coronary artery bypass graft, PCI, or diagnosis of ischemic vascular disease must take an aspirin or another antithrombotic. This is followed by the probably either primary care provider or cardiologist. And then for comprehensive diabetes care, one of the core measures that's really important is we look for any hemoglobin A1C that's greater than 9.0%. And this indicates very poor control because, as you know, hemoglobin A1C really looks at an average blood sugar for the last 3 months. And hemoglobin A1C should be drawn at least yearly on anyone who has diabetes. And the actual goal for someone with no comorbidities or glycemic risk is less than 6.5%. Another important core measure is medication reconciliation. And any discharged patient from an inpatient facility must have medication reconciliation within 30 days of discharge. This generally includes an appointment with a primary care provider where they go over all of the medications the patient was discharged on and then what they need to continue, stop, or any new meds that they need to be started on from that point forward. Cervical cancer screening is for women 21 to 64, and those people should have cervical cytology performed every 3 years, and women 30 to 64 should have cervical cytology and HPV co-testing every 5 years. There are, as I said before, other core measures that are important. I would say these are probably the most important ones you would need to know for the exam. And then the Joint Commission has national standards for quality measures that must meet the following strict requirements. They relate to patient safety or quality of care. They positively impact healthcare outcomes. They must meet or surpass law and regulation and can be accurately and readily measured. And then the Centers for Medicare and Medicaid Services grouped outcome measures into 7 categories weighted by importance. And so the first 4 are considered the most important: mortality, safety of care, readmissions, and patient experience, which we all know. We know that safety is always considered huge. Within that comes falls and the hospital-acquired infections and wounds. Anything that can happen within the inpatient care facility would fall under safety of care. And then readmissions we look at, especially those less than 30-day readmissions for anyone. We particularly look at heart failure patients because those are the ones that get readmitted quite a bit. And then patient experience. We certainly want to know what kind of experience the patient had, and all kinds of things go into that. Pain is one of those. And so those first 4 are the most important. The last 3 are only 4% of the outcome measures, so they don't carry quite as much weight, but still important. Effectiveness of care, timeliness of care, and then efficient use of medical imaging. So looking at blood pressure, the classes are important. And if you look at these, you can see that there are, I shouldn't have said classes, I should have said stages, excuse me, stage 1 and stage 2. And look primarily at the numbers. So especially stage 1 and stage 2. Stage 1 is a blood pressure of 130 to 139 over 80 to 89. And then you follow this algorithm down, whether or not the patient has any atherosclerosis or not. If they don't, non-pharmacological therapy is fine. Reassess in 3 to 6 months. If there is some atherosclerosis, you say yes to that and you follow the right arm down. Non-pharmacologic treatment and blood pressure lowering medication, reassess in a month, and then just keep following it down. Stage 2 hypertension is blood pressure greater than 140 over 90. And again, we put them on a blood pressure lowering medication and always non-pharmacologic treatment as well, reassess in a month, and then follow the algorithm down again. You might want to take a screenshot of this or notes or whatever will help you and come back and look at this again later. This is an important component. And then last, or next to last, we have the Curb 65 algorithm. This is used for patients who come into the emergency department or outpatient, I guess, with a diagnosis of pneumonia. Group 3s, those who score a 3 or higher, have to be managed in hospital. Those who score a 2, we do consider hospital supervised treatment, but not always. They can go home sometimes. Group 3s are definite hospitalization, sometimes and many times in the ICU, especially if they score a 4 or 5. This is another one you'll want to take a look at, know what CURB stands for: confusion, urea, respiratory rate, blood pressure, and age. And then lastly, we have the atherosclerotic cardiovascular disease algorithm. And this helps clinicians to know whether or not to start a statin. So we do look at age, and we also look at LDL. LDL is really the primary one we look at, especially if it's over 70. Over 70 is generally when we want to treat. And you can see kind of there what's considered not high risk and then very high risk, and you could follow this down. This is another one you'll probably want to take a screenshot of and look at again. Again, the number there really that we're looking at is 70 for LDL. Greater than 70, we are most likely going to treat. Less than 70 is considered of lower risk. There are many more components to this unit. I'm not really pointing those out as much because I do believe they're a little bit more of common knowledge type content. Of course, if you have any questions about them, contact your assigned course instructor, and we are happy to help you. Thank you.